Good morning, everyone. Without further ado, let's go on with this updates and breaking news session now. Mr. Darren Smith from UCL London will come and tell us the year of highlights in endourology. Thanks, Darren.
Morning, everyone. Nothing like adding to the challenge by being invited to walk up a set of stairs. I'm glad I'm wearing my sensible shoes this morning. As you'll see on the first slide there, I have sort of self-styled myself as an endoluminal endourologist, and what an honour to follow two endoluminal greats this morning. I was also particularly interested at the new concept of a psychourologist, who's going to have their hand up first to be one of those. So what I'm going to do quite literally is a whip through what last year kind of really gave us in the published papers. This is not really an update about what we've seen here brilliantly this week. Imaging, PERC, ureterorhinoscopy, ureteroscopy, stents, shockwave, conservative management. Indeed, that is the whole of endoluminal endourology on one slide. So I shall now go through and make some of the key points. As far as imaging is concerned, I think we would all agree that less is best. We're particularly conscious now of radiation dose. So this big series that came out in the New England Journal last year, as comparing all of those patients that go through A&E, 2,700 odd of them, who were randomised to a point of care in the A&E department ultrasound against one performed by a radiologist against the sort of standard practice that we would have of spinning them straight through the CT scanner. A lot of things that I've summarised on there. I gather this is all being videoed, so if anybody wants to scrutinise the data subsequently, they can. But the highlight points are this, that even though those patients who had ultrasound, many of them went on to have a CT, overall, in those groups, the patients that were CT'd first had a significantly higher overall radiation dose. And the reason for that is that if you can screen out the patients that don't need a CT at the beginning, we know from all of the work in the UK and indeed around the world that about half of the patients who come in with classic ureteric colic actually don't have a stone on a CT. So if you avoid the initial CT at the beginning, then maybe you're doing other patients a favour. Slightly closer to home, we've heard it mentioned already this morning, the advantage of pulsed fluoroscopy. Pulse is at 4 frames per second as opposed to continuous, which is at 30. And by making a very simple setting change on your image intensifier, you can reduce your overall fluoroscopy time and therefore dose quite considerably. Consultant outcome publication is of course the next thing, and what do we compare ourselves against? So for the surgical things here, I've got some big studies that give us really kind of what we're aiming at. This one on PERC comes from Crow's, that's the research office of the Endourology Society, and this is a summary of their 25 papers from this massive database about PERC, the majority of which were performed prone, and ultrasound in this series showed a reduced radiation exposure and quicker puncture time. These are the sorts of things, if you're auditing your own data, that you've got to watch out for. This is the sort of complications that you can expect. Fever in 1 in 10, and of course you can reduce that if you give antibiotics. Bleeding, about 8%, 1 in 12, and you can reduce that if the tract size is smaller, as we've already so beautifully heard. Optimal case volume per centre, about 120. Not many of us in the UK get close to that, but maybe we will if we refer the difficult ones on. So if you're looking for cases not to do in your series and to add to somebody else's complication rate, chronic renal failure, solitary kidney, older patients, and what's now being called the super obese, are the people to pass down the line. As far as flexible ureterorhinoscopy is concerned, it's all about stone clearance, and stone clearance depends primarily on stone size. So we've heard that too, and as you see, as the stone size gets bigger, through 10 millimetres, between 10 and 20, actually really with a cut-off of 15 millimetres, the stone is not a one-dimensional structure, it's a sphere, and beyond 15 millimetres, the volume starts going up exponentially. Those are the ones to do a PERC for. You've already seen this mentioned, so this is now revision. This is how the ureter looks after an access sheath has been put up. And in Manage's own data, this is always a stenter against a selective stenter. Then if you've got a patient who has an access sheath who didn't have a stent before, they're going to have a substantial amount of pain afterwards if you don't put in a stent. Ureteroscopy. Again, Crow's data, massive numbers, multi-center. This is real-life surgery by real-life surgeons, and the sorts of things that we need to aim for as stone clearance in a single procedure go up nicely in fives. Proximal ureter, about 85%, mid-ureter, 90%, distal ureter, 95%. If you've got stones in multiple locations, then of course that's more challenging. What sort of complications should we expect? This is an interesting point for consent. 8,000, this is a single centre series. The one right at the very bottom is the one to draw your attention to. We've all seen pictures of it. None of us have ever seen it personally, of course, of the catastrophe of a ureteric avulsion, gloriously rare. Shockwave lithotripsy, Manoj mentioned it, that selection is the key. There are lots of different ways of doing it, but this one is quite elegant. It's called the triple D score, D for density, D for distance, and D for diameter, although quite rightly they've used volume. And if all three parameters are favourable, you get a much, much higher stone clearance rate than if none of them are. Stents. We like them because we can sleep at night. Patients hate them because they can't. And although there's been lots of things done about stents, shorter, fatter, thinner, drug-eluting stents, doesn't matter what the colour is, if you put one in, the patient's going to get discomfort. So the best way to alleviate that is to leave it in for a less amount of time. This was a randomised study against stents on a string. The Americans call it on dangles, and it's easier and quicker to get the stent out because the patient can do them at home. This is actually what that American series were doing. No difference in complications with the stent in, and no difference in the discomfort of the stent coming out. The only problem with this is the stent coming out too soon, and therefore if you really need a stent, then you should just put in an ordinary one. So finally, and I think for us really importantly, this is the real take-home message. This is the change of practice series of slides. Lots and lots and lots and lots of data, including meta-analyses about the use of alpha blockers in patients with ureteric colic. But here a really big homegrown British study led by Sam McClinton, over 1,000 patients randomised. The biggest number in any of the other meta-analyses is about 100 patients. So 1,000, it's our population, randomised for ureteric stones between placebo, tamsulosin and nifedipine. No difference. 80% of those stones were expelled, and it didn't matter what drug they were taking, including nothing at all. So no difference between placebo, no difference in the time to stone passage, no difference in analgesic use, and this was the same right out to 12 weeks. It's a change in practice slide, that one, and I think that the conclusions of the authors, as is written in the paper, is worth emphasising. It's conclusive evidence that the effect of both of these drugs in increasing the likelihood of stone passage as measured by the need for intervention, this is a relevant measure for the patient, is close to zero. Finally, a plug, I think we're allowed to do that as our last slide, a plug, 33rd World Congress of Endourology. It'll be in London. It's right at the beginning of October. It's going to be a fantastic meeting, and enjoy the rest of this morning. Thank you.